It's in the giving. We are found, yeah. You could barely change.
Welcome to A Medicinal Mind, Wisdom and Well-Being, a podcast dedicated to the telling of authentic stories and the sharing of insightful wisdom, exploring science and spirituality, medicine and Mother Nature. No topic is off limits when it comes to growing our personal understanding and supporting our collective well-being. With your host, Dr. Rob Abbott, a family medicine resident practicing spiritually focused and evolutionarily informed functional medicine, we hope to nourish your being so that you can flourish in whatever the moment has called for you to do.
And I know you tried.
In episode 19 of A Medicinal Mind, Wisdom and Well-Being, I share a conversation with integrative psychiatrist Dr. Will Vanderveer. As you will hear in the podcast, I first came across Will as part of his joint presentation with Dr. Janet Settle on the February 2017 edition of the Evolution of Medicine's Functional Forum, The Evolution of Integrative Psychiatry. Serendipitously, before I even had a chance to reach out to Will to thank him for his inspiring presentation, he contacted me following the release of my ebook on integrative and functional medicine education, and a friendship was born. In our conversation today, we dig in deep as Will shares his revolutionary framework for approaching mental illness, one where Will recognizes a trinity of interconnected and primary contributions to a patient's present illness, including psychospiritual disturbances, physiologic imbalances, and a patient's presenting symptoms. Will provides us with some practical methods for using lifestyle approaches to address mental illness, and outlines how he incorporates both medications and lifestyle medicine in his practice. We explore some of the fascinating science behind the bidirectional gut-brain axis and the influence of various dietary and environmental factors, such as gluten and glyphosate, to disrupt one's optimal functioning. Seeking to revise, or perhaps completely dispel, the currently espoused neurotransmitter imbalance theory of mental illness, Will walks us through the inflammatory cytokine, or the inflammatory brain hypothesis, and its power, in combination with the exploration of adverse and traumatic experiences, to explain much of our current mental health crisis. Will offers up some of his personal research as well, working with psychedelics in combination with various forms of cognitive therapy in order to help those suffering with PTSD and others negatively impacted by adverse childhood experiences. We even start to dabble in and explore the emerging field of genetics, pharmacogenomics, and the role of genetic testing to inform treatment in mental illness. There was so much to cover in this one podcast, and we will certainly have Will back for more of his insights and wisdom. If you enjoy the show, please leave comments on our podcast page, follow us on Facebook, and consider leaving a review in iTunes. We are always inspired to hear your thoughts and recommendations for future podcasts or articles. I am grateful as always to have such passionate speakers on the show, and look forward to bringing you more
Will,
episodes
thank you so much for
as we continue this amazing journey
a podcast
together. I hope you enjoy the show.
I feel, quite honored to have you on to talk about a lot of your work, and really just, like I said, I'm so grateful to have kind of crossed paths with you in a rather synchronous way. But would love for you to start by kind of sharing a little bit about you and your work.
Great. So I'm a psychiatrist in private practice. I also do clinical research on PTSD and teach residents down at the medical school near where I live. Those are my three main things.
So basically what you're saying is you have the capacity to, we'll say, indoctrinate or maybe expose residents to some of your methods and thought processes.
Yeah. It's part of the idea is that it's much easier to create new patterns of working with patients from the beginning than it is to retrain later. So we're hoping to really help people see a bigger picture in psychiatry of what can be done and what's out there, and what's effective, what's not, what does the data show. There's just a great big world outside of what I learned in my training as a psychiatrist.
Well, I'm so grateful that you're doing, that work. And I stumbled across you back in, I guess it was February of this year, when you appeared on the Evolution of Medicine's functional forum with, I guess it was sort of, entitled, the future evolution of psychiatry. And you came on and sort of in a joint presentation just, I think, blew the audience and, myself away with this remarkable model and way of thinking about psychiatric illness. And I was just, like I said, I was so amazed by this, already sort of thinking in this direction, but, really wanted to, after hearing that and connecting, have you come on to share that framework and how it's evolved, because I think so many people, could benefit from hearing about how you approach mental illness. So please feel free to start wherever you would like in this story or in this framework.
Sure. So we start our training in integrative psychiatry with a map that we presented at the functional forum, and maybe I can get you a copy of that so you can put it up with the webinar, so people can see a visual of what I'm going to start talking about. The idea is that the symptoms that we see in psychiatry are not diseases; they're final common pathways of something deeper that is out of balance in the person, and that those imbalances can come from a broad variety of different sources or different causes. So we look at environmental causes, we look at lifestyle causes, we look at relationship causes, we look at even spiritual causes, and so forth. And these are the sort of funnels that bring the original stresses down into a person's physiology. And then within the physiology, we have these genetic differences and detoxification pathways that may or may not work very well. We have methylation pathways that could be off. We have gut problems that can cause all kinds of issues with brain function. We have hormonal imbalances like adrenal fatigue and other kinds of estrogen, progesterone, testosterone problems. So all of these sort of wheels that in the physiology get affected by the inputs into the physiology. And then at the end, at the very bottom of the output, we have psychiatric symptoms. And there can also be other physical or medical symptoms that go along with that. I think one really good example of this in recent lit searches is the work of Charles Raison, who I think is at Wisconsin now, used to be at Arizona, and he has been really exploring this concept of inflammatory depression and basically treating depression with anti-inflammatory strategies and having success. He published in JAMA, I think it was last year, a pretty good study on a TNF alpha, was it TNF blocker for depression? And not all depression is inflammatory, but the point being that if we're looking at final common pathways, we really need to be looking at what's causing the symptom. We need to stop thinking that symptoms are diseases like we're all trained to think with the DSM, with the exception of maybe PTSD. Otherwise, we're thinking that these are sort of quote-unquote biological illnesses that don't have any real basis in physiologic origin. And we need to go to the root causes and treat the root causes. So our version of integrative psychiatry is take the whole person, look across the board at the inputs and the outputs, investigate the physiologic pathways, use symptom mitigation to preserve treatment alliance, but only in the service of buying time so that we can get to root causes and resolve them. Symptom reduction is really helpful. People love it. They appreciate it. It helps them get through the day. But I just never felt satisfied as a psychiatrist just helping people get through the day. So I guess that's it in a nutshell.
Yeah, well, I would definitely love to have a visual for people to see, because I think it just, it cements this integrated framework as you just, so elegantly, put out. And, I remember, when you first presented this, seeing and coming across that idea of treating symptoms. And I think, even in the space of functional medicine or, integrative psychiatry, people have, felt a little weary of treating symptoms, per se, because it doesn't really necessarily address root causes. And I try to bring up the idea of, there's multiple levels of treatment. So yes, in certain cases, you may need to address symptoms in order to increase engagement. And you guys talked about this, tremendously, on this sort of spectrum of how can you get someone in that sort of middle ground where they're going to be willing to make some changes. And perhaps you're going to have to address some symptoms, while also looking at root causes and while also looking at some psychospiritual disruptions. And so it's just not as simple as just physiology or just managing symptoms or thinking everything is in the person's head. And I was just this came up and with one of the patients that I saw in the hospital, and it just we talked about this idea of mind, body, body, mind, and I've kind of gotten to the point where it's to me I don't even see the dichotomy between the two. It's people are often just hurt when they're told it's all in their head or this is just purely psychiatric. And I just I think you kind of alluded to that. It seems so myopic to think there's no underlying sort of organic physiologic disturbances in connection with someone's psychospiritual symptoms. And I just we had a long discussion, and it was the first time someone had ever told him, like, look, there's still probably some things underlying. Maybe we haven't found the traditional diagnosis that traditional medicine likes, but I can almost guarantee you there's some underlying things that will help to balance your symptoms. And so yeah, really was it was really refreshing to see you guys talk about that. And perhaps you can maybe kind of push us more in that direction with an explanation, maybe how that came about or how that's evolved for you.
Mm-hmm. Well, we really like the metaphor of the warning light on your dashboard of your car, and we don't go to the mechanic and ask the mechanic to turn the light off on the dashboard. We go to the mechanic to get to the root of the problem, right? I mean, that's what I think conventional psychiatry often is about, is going to the mechanic and asking them to turn the light off on the dash without looking what's underneath, what's going on there. For example, you could look at, well, let's just take, for example, the gut-brain connection. And one good maybe place to start that conversation is around Roundup or glyphosate, the Monsanto product. And, I working and practicing in Boulder, I get a lot of people coming in here talking about, eating well and eating organic and all that kind of thing, which is great. I totally support that. But one of the problems that a lot of people don't know about with Roundup is that American wheat, because it's so genetically modified to have so much gluten in it, which is a whole nother problem with the gut we could talk about too. But the glyphosate is used to ripen the wheat berries because when it's genetically modified to have so much gluten in it, it's really greasy. The berries are very greasy, and they can break the combines that harvest the wheat. It was discovered a few years ago that you can put Roundup on wheat berries to dry them out. So they're drenching American wheat with Roundup, not for weed control, but to make the berries dry, to make the combines work better. So eating American wheat means almost by definition you're getting a ton of Roundup in your system. Why is Roundup a problem? Well, the published pathway that Monsanto describes is called the shikimate pathway that is interrupted in the weeds. So shikimate pathway kills weeds when Roundup is put on the weeds. That's fine. But for humans, it's not fine because the shikimate pathway is used by evolutionarily important bacteria in the gut to produce tryptophan for us. So, you think about tryptophan, you think about serotonin, right? 80 to 90% of the serotonin in the body is produced in the gut lining. If your gut is full of Roundup, then your bacteria that make tryptophan are going to be able to make as much tryptophan, and you're going to have a lot more problem making serotonin. Therefore, you're going to have more problems with anxiety and possibly depression as well. So, it's just a great example for me of taking the environmental approach of looking at, okay, here's a symptom of anxiety or depression. Okay, what's going on with the person's diet? Oh, they eat a lot of weed. They eat sandwiches every day. I treat a lot of college students who are eating pizza and mac and cheese and sandwiches all day long.
You mean college students don't have the best diets?
That's what I found. I didn't in college, that's for sure.
My last podcast, I was just talking with a good friend of mine, Mike Ettlinger, and we harped on that. We were like, most illness kind of starts in some arena around college. You just you check off all the boxes: toxins, alcohol, poor diet, not sleeping. You're stressed about silly relations. It's like, wow, how do we even survive to begin with?
I know. Yeah. So you can trace things through and see that if we help that person to understand the impact of their diet and you can actually you can test people for glyphosate now, and it's not that difficult to do to see if they're overdosed with Roundup. So then you can remediate the gut. Then after the gut is repaired, you can begin to recover brain functioning, and you can see a real change in terms of anxiety and depression just from that. And I have so many examples in my practice of seeing people who, and I'm not just like, this isn't like a soapbox about weed and gluten. I mean, gluten is huge in my practice, but at this point in time, gluten is sort of yesterday's headline. It's not even really on the cutting edge anymore. It's pretty mainstream, at least in integrative circles. But eliminating gluten from a person's diet, a person who's sensitive to gluten, can have a massive impact on anxiety, mood, insomnia, irritability. I've treated people with bipolar disorder who needed to be on multiple mood stabilizers to keep themselves under control, keep their mood under control, who couldn't begin to do, let's say, mindfulness training because they were so irritable and so scattered. And then when they stop eating gluten, they can, they come back to the office and say, wow, now I can actually do what you've been trying to help me with in psychotherapy for all these months, because now my mind is quiet, simply from eliminating something out of the diet. So in our integrative psychiatry model, the role of inflammation, the role of the gut and gut health is one huge branch of the tree, and then the other side is really working with adverse childhood experiences and the prolonged inflammation pathway elevations that come from that.
Wow, there's so much there I'd love to get into, and I think I'd love to maybe take this in that sort of childhood experience direction. But before we go there, I was just sitting here, listening to that description, and I'm such a science geek, so I love those pathways, and I thought it was just interesting. This past week I was in Seattle for the Ancestral Health Symposium, meeting some really wonderful folks doing really cutting edge work. And one of the presenters brought up this topic and was talking about glyphosate and Roundup, and they had actually, and this was something I hadn't come across, I pointed out that supposedly, more that the primary issue comes from not technically glyphosate and it's sort of that molecule, but it's in Roundup, the fact that it's bound to this other just sort of disrupting chemical that I guess makes sort of allows it to be permeable to certain membranes and essentially makes it sort of bioactive, and that's sort of the main issue. And they brought up the same thing you just said about like the amount that gets put on wheat sort of in the winter time for this kind of ripening process, and just how ubiquitous it's becoming. And, so that was, incredibly new to me. And then another researcher brought up some very interesting studies on, so yes, like you kind of mentioned, gluten's becoming very well known. It's sort of the integrative and, psychiatric world. And, you hear that, the statistics as well about serotonin and being produced in the gut and its, interplay with, gut bacteria. And, they presented some studies that talked about, essentially we need to, certainly expand our mindset to realize that we have, there are cells, naturally occurring cells in the gut that are responsible for producing serotonin, and they were basically showing associations with certain, basically treatments and probiotics and things, showing that there was increased production of serotonin in these specific cells and sort of signaling in these pathways, and actually realizing it's a slightly different mechanism than we talk about, like the gut bacteria themselves producing tryptophan, and realizing there's all of this endogenous signaling going on. And like I said, it just sort of opened my eyes to see, because I think some of this too, we bring up this idea of serotonin or the precursor tryptophan, and it feeds in to that neurotransmitter model of depression. And I've always been like, guys, like it's great that we talk about gut bacteria, serotonin, but it's really more nuanced than that, because you can just get back to basically saying, well, I'm going to heal your gut, and then that's going to give you more serotonin, and that's what's deficient and why you're feeling depressed. And I'm like, well, actually, that, back to the inflammatory story, that's not really the whole story. And so, was curious what your thoughts were regarding the interplay of, these neurotransmitters and certain, cognitive networks and this more sort of inflammatory model or expanded model of, environmental exposures and what have you. So we could, go into this realm if you would like.
Yeah, I mean, I think you're right that the neurotransmitter model of mental illness is really weak, and it's really never been supported in the literature. I mean, I think it's more of a marketing strategy from drug companies, and I think that's sort of how it arrived on the scene. And then psychiatry bought that hook, line, and sinker, and it's unfortunate because people are still educating or I guess you could say miseducating their patients that. This is why you need Prozac, is because you have a serotonin problem. There is some evidence to suggest that SSRIs are anti-inflammatory. And I think that as we go down the road in the next 10 years, 20 years in psychiatry, we're going to focus much more on glial cells in the brain and sort of the milieu that neurons function within. And I think this is one of the reasons why you see anti-inflammatory approaches working well for depression, is that the immune system in the brain is playing a much bigger role than any of us realize in terms of brain symptoms or psychiatric presentations.
Yeah, and I really loved this idea that you talked about, introducing treatment, sort of anti-inflammatory treatment, providing major relief for individuals. And I think just in the past month, there was a big trial that had some fancy acronym, and essentially it was one of these. I think it was like a sort of a monoclonal antibody to like IL-6, one of the interleukins, one of the inflammatory interleukins, and I forget the name, super complex. And they were looking at heart disease and thromboses, or basically clots in the both the lungs, or the vasculature of the lungs, pulmonary embolus and coronary or heart thromboses, and saw dramatic results with treatment with this sort of anti-inflammatory drug. Essentially, it was basically blocking the action of these inflammatory cytokines, and it was being espoused as this incredible new breakthrough. And yes, it was great from a mechanistic, like here, we've been talking about this inflammation, as a major mechanism for these disease processes. Realistically, this drug is one of those like I mean, it's going to be like $1 million for like one dose. So it's not going to be like a realistic treatment, but mechanistically finally giving, more evidence to the fact that we need to look at the root causes leading to this kind of common final pathway, as you just said, of this inflammatory cascade. Our treatments are not going to be another drug that's, a monoclonal antibody. We need to stay away from that, but realize we can get into the system if we look at some of the root causes of inflammation. And like I said, I was just, I really like seeing that literature, and hopefully it just doesn't get taken in the pharmaceutical direction.
Well, yeah, I mean, it might be something similar to what the work I mentioned about Charles Raison and TNF-alpha and blocking that with he was studying a monoclonal antibody block for that part of the immune system. And the problem with aside from the cost of these drugs, anytime you take a single intervention and you wipe out a part of human physiology, you're creating a lot of other disturbances in the physiology, right? So with these monoclonal antibodies, one of the well-known risks of taking those for inflammation, and they're indicated primarily for rheumatoid arthritis and autoimmune diseases, is cancer, because our immune system is there to clean up cancer cells. We all have cancer cells in our body right now. Again, it's another example, I think, of conventional sort of patent-driven, profit-driven medicine of, okay, well, here's a novel compound that we invested $1 billion into, and we're going to get it on the market, and we're going to, it's going to cost, I don't know what, those cost a lot of money. I think it's a lot more
They're
than...
in the, few thousands of dollars per injections, like $3,000, $4,000, or $5,000 for monthly injection. It's nuts.
It's incredible. And so from an integrative perspective, you would want to ask the question, well, is there a way that we could boost the immune system or balance the immune system? And that's why gut health is so important, because the exposure to the do you know what I mean when I say the old friends hypothesis or the hygiene hypothesis?
Yes,
with that?
I do.
Okay. So Charles Raison and a few other guys kind of came up with this view that you need to have these ancient bacteria in your system as soon as possible after birth to train your immune system to work right. And if those guys aren't there, then you end up with this imbalance of pro-inflammatory, called T effector cells in the gut lining, too many of those, and not enough T regulatory cells, or the peacemakers, or the kind of UN of the gut lining. So
I like that analogy.
Yeah. So you've got too many soldiers with guns and not enough peacemakers. And so then you end up with, autism is a great example of a psychiatric problem that almost all kids with autism have gut issues. And that's why people have looked so carefully at glyphosate and autism, probiotics and autism, gut permeability and autism. And the people who don't get exposure to old friend bacteria are much more likely to get autism. Once that immune system is set up in the first couple of years, you can do things to try to promote T regulatory cell activity in the gut, but you're fighting an uphill battle at that point because the balance has already been set up. The cells have been differentiated. So, it's why don't we try to balance the anti-inflammatory and pro-inflammatory signaling in the body rather than just simply wiping out a certain part of the natural ecology of human physiology, right?
Yes, it is. You're speaking to the choir with that, and I another thing that sort of came up at this conference is what you just described. There's this relatively critical window of development of the immune system, and like you just said, once we get beyond that, yes, we have certain therapies and approaches that we can do to potentially help to balance the immune system, but you can't get back that period of exposure and tolerance and the differentiation of these cells, and potentially based off of those early life exposures, you could theoretically develop an immune system, we're calling sort of the modern immune system. And
Right.
actually, some of our approaches later in life, or later down the line, that attempt to maybe emulate our ancestors and kind of superimpose a hunter-gatherer diet or exposure pattern to someone who has a modern exposure immune system, that's actually, that it can be a clash of systems and cause bigger issues. And so I've really tried to speak to my colleagues and really have us take pause before we prescribe antibiotics to children, or make sure we identify early on the kids who are C-section babies who are being bottle fed and maybe are having different types of exposures at home, and really try to intervene as soon as possible with various therapies such as probiotics and modifying their environmental exposures, just knowing you're not going to get that period back. And this is not something that's unique in and of itself. I mean, you ask any medical person who's gone through school, and they'll remember learning about the development of visual pathways and this sort of critical period for the eyes. And you go to an ophthalmologist and they talk about this concept of amblyopia and needing to fix or patch an eye because of potential concerns that essentially if there's no input into into an eye, they're not going to develop the visual pathways. And it's in language development, and there's all of these things that we know that and are well identified as these sort of critical period systems that are being developed. And it's just now, I think, we're becoming aware of the immune system as being another one of those systems that has this critical period. And so thank you for kind of outlining that in a very practical framework. And I guess to get even more practical, I would love to maybe hear what some of your therapies. So if we're not going to be giving people monoclonal antibodies to prevent inflammation, you talked about sort of one type of dietary approach, but would love to maybe go into some of your therapies to address maybe some root cause disturbances or root causes of inflammation.
So again, we try to buy time and build alliance and get people feeling better by symptom mitigation initially, while we're also looking at root causes. So I regard treating inflammation as another version of symptom mitigation. So I don't think it's enough to just say, okay, well, you're inflamed, so here you go. Let's take some curcumin because we know that'll turn off NF-kappa beta and that'll drop your CRP and then you'll feel better. And that is true, and that will help. So for people who have high levels of inflammation, they have comorbid autoimmune diseases, their CRP is above 10, that kind of thing, then, I usually will think about using curcumin right off the bat, 500 twice a day, maybe 1,000 twice a day. There's a study out of India that compared an SSRI, I think it was Lexapro, to curcumin, 8-week trial, and they both separated from placebo. So I thought that was a really interesting study. The reality is, as I mentioned before, that not all depression is inflammatory, and so I don't think there's a one-size-fits-all. But back to what you were saying is, how do you get to the root causes? I think we have to think about what caused the inflammation if we're going to talk about inflammation as a pathway. And again, for me, the two main things are what we were just talking about, missing that critical window of opportunity in the first 2 years. That person is probably going to come in with a history of environmental allergies, asthma, that kind of thing in childhood, which is oftentimes reflective of having missed that window where they have, more pro-inflammatory cells in the gut, and they're reacting to lots of things because the soldiers are shooting their guns for no good reason. The other common pathway of prolonged inflammation is adverse childhood experiences. So we have these huge prospective studies out of the UK, with ends of over 3,000 people, where They look at prolonged elevations of IL-6 and C-reactive protein for years, decades in some cases, after childhood maltreatment. So we know that one of the ways that in the ACE studies where you see these very high levels of inflammatory diseases, whether it's cardiovascular disease, lung disease, cancer, physical diseases in people with a lot of ACEs, that part of the mitigation of that is through these pro-inflammatory pathways. So my sort of basic assumption when I see a new patient is that they're probably going to have some combination of either adverse childhood experiences or gut issues related to diet and related to missing critical windows of development, or taking a lot of antibiotics in childhood, or being breastfed, or being delivered by cesarean. So all of these things play a role. And obviously, we also do family history, and we think about, sometimes we do genetic testing on people. I know that's something you're interested in. So getting the root cause taken care of, doing gut remediation, doing trauma therapy is often needed for people dealing with adverse childhood experiences. I think this is the best approach we have at this point for really getting to the root causes of inflammation.
Yeah, my girlfriend's just started her fellowship in child psychiatry, and I mean, to them, it's complete common knowledge that these children can basically be coming in with this sort of trauma inflammatory phenotype or pattern of gene expression that has been going on for years due to underlying adverse experiences, and a lot of their work is trying to elucidate how to what were the primary experiences and how to help the child sort of resolve some of those issues so that we can reverse this inflammatory phenotype. And I mean, talking to them, they completely get it now. You talk about these things in some other circles, and people look at you like, why would it matter what happened to you at age 5? I'm 45 now. I don't see how that would be affecting me. And it's sometimes a far reach for people to say, like, why does that matter? And was curious to maybe see, one, how do you explain this relationship? Because yes, we have the science, but science, just throwing science at people isn't necessarily going to have them buy into this. And then sort of second, what are some of the therapies or psychotherapy approaches that you use to work with people with these traumatic or adverse experiences?
So in the beginning, when I was still a resident, I heard about EMDR, and I have to thank my training director for giving me permission to go out and get trained in EMDR and then find an off-campus volunteer faculty to supervise me. That's how I met Janet Settle, who presented with me at the Functional Forum. She was my supervisor for EMDR cases as a resident. And I liked EMDR for a while for treating trauma. But after a while, I realized that it seemed to work better for discrete, single event, adult onset PTSD. Works great for that. It could just be a handful of sessions for some people. So it's a great tool to have in your kit. The problem is that most people I work with have complex trauma or early childhood layering, layer and layer and layer of trauma. So I decided to go look for a different treatment that was better designed to deal with that. And so out here in Boulder, there's an institute that was started by Peter Levine, who is well known for his book Waking the Tiger, and he also has a book called Healing Trauma that's really, I think, really helpful for patients to read. And his approach is called somatic experiencing, which means basically that it's a somatic approach to trauma, meaning you're working with people to, first of all, develop a language of sensation in the body so that they can talk about their felt sense and their physical experience in their body. And then helping the person to revisit the trauma and sequence the events in the body that need to happen for the body to catch up and realize that the person is no longer in a dangerous situation. Peter's hypothesis was that what happens at the point of impact of a trauma is that your body kind of gets stuck in that moment. And there are different kinds of symptoms that come up for different people depending on with their PTSD or with their trauma history that is sort of relevant to what part of the natural sequence of that we go through when we encounter a threat, from startle to identifying the threat to executing a sequence of events to get away to knowing that you're safe and secure again. And so with somatic experiencing, you can deal with some of these earlier patterns. And I was pretty fired up about that for a number of years, and I still use it in my practice. But it came to me at a time when I didn't know that there could be even more accelerated treatments for trauma, and that's where my work with the Multidisciplinary Association for Psychedelic Studies came in, and I started helping out with MDMA PTSD trials. And, we finished our phase 3 part of the process with FDA, and we're now about to start a phase 3 trial, which FDA has recently granted breakthrough designation for MDMA psychotherapy for PTSD. So we're really excited that this could, cut years of recovery off of people's lives.
That's, we've talked about outside of this podcast before about some of your work with these psychedelics and these adjuncts, and I think it could be a whole nother podcast, and I think perhaps we'll have to have you come back to specifically talk about some of those things, and because that too, once again, you bring up these certain drugs, and people immediately say like, "What kind of craziness are you doing in your clinic with these?" And I remember meeting wonderful gentleman. I guess he's up in Johns Hopkins at this was a conference last November, and starting to work with psilocybin, and they were using things not really in the medical setting. They were looking at like long-term meditators and sort of the spiritual experience, and they were looking for drug naive people. And I remember going up to him like, I know I'm not quite a long-term meditator. This sounds like such a cool thing. Unfortunately, my sort of number of years of meditation wasn't good enough for them. But I was just like, we had this great conversation about the role of these adjuncts and therapies, and I think it just speaks to our greater need to pass non-judgment and to practice openness with any sort of potential modality. And I mean, a lot of things get stigmatized, especially when it comes to mental illness. And I think I'm grateful that you have entered this arena to do some of this work. And perhaps I'm sure you've probably been targeted to say like, what are you doing with these drugs and these therapies? But so thank you for bringing that up. Like I said, I'd love to. I think maybe we could have a whole another show about that. I did kind of want to see and perhaps get your thoughts. You mentioned a little bit about the role of genetics. So we've been talking about all of these experiences and the environment, and addressed a little bit of sort of family history and these various inputs into what could cause someone to be suffering or to flourish. And genetics and epigenetics, this sort of pattern of expression, are getting major headlines now. But also in the same line that we can sort of get nearsighted into having a model fit a pharmaceutical model where this genetic pathway or genetic pattern of expression matches, oh, this is a really good drug that could target this. I've kind of seen a little bit of, in sort of the psychiatric world, some testing, and I've seen some of the results of basically genetic testing, looking at various, a lot of them are enzyme pathways, or certain receptors for serotonin, dopamine, and these things, and being able to predict. This is what this company is sort of saying, being able to predict someone's responsiveness to certain pharmaceuticals. And there's other things embedded in the genetic report which I'm interested in, and potentially someone's susceptibilities to various adverse experiences. But once again, I sort of was looking at some of these genetics and being like, so you're still fitting this model to say like, oh, I should try this drug. And maybe I'm being judgmental again and saying like maybe I'm being nearsighted to say that I should could use this information if someone's symptom burden is quite high. But I look at that and I'm like, is this really the direction we should go into? And just wanted to get your thoughts about the role of genetics specifically in psychiatry, and maybe this concept of pharmacogenetics, and how our genetic and epigenetic patterns of expression can affect how we respond to certain drug therapies.
Mm-hmm. Well, I think a lot of it is economics driven, because I do some of that testing in my office, and I think that it's been a mixed bag as far as how useful that can be. One place where I have found that useful is in the treatment resistant depression, or like we were studying in the MDMA PTSD trial, the chronic treatment resistant PTSD, and looking at is the person going to are they much more likely to have side effects to X, Y, or Z medication, or what's their serotonin receptor profile look like, and that. So I think I'd say it's economically driven, because the companies that I know of anyway that are doing genetic testing in psychiatry are gearing themselves toward the conventional psychiatrist who basically medicates everybody and doesn't, really think about psychotherapy very much, doesn't really think about adverse childhood events and the effects of that on inflammation pathways and so forth. I think that there are groups out there that take a much more, at least maybe not much more, but they do have some tests that are kind of more in the functional medicine or more in the integrative kind of vein with genetic testing, but for the most part, I think they're companies that are trying to get a toehold in the psychiatrist's office to get people testing people. And since I don't do primarily a pharmaceutical practice, I do prescribe medications for sure, especially in the beginning. I'm trying to mitigate symptoms. I don't really find testing about which SNRI is a better choice for this patient very useful. But when somebody's tried and failed dozens of different medications, and you get the genetic test and it shows that they're genetically basically allergic to every medication they've ever tried, then that can be really reassuring for patients that it's not, so to speak, in their head, that they're dealing with physiologic pathways. So it's kind of mixed as far as that goes.
Yeah, I really do feel the future is trying to further elucidate and integrate some of these pathways. And I know, like you said, from some of this functional vein, looking at some of these corollary physiologic pathways of detoxification and sort of someone's susceptibility to oxidative stress and various methylation pathways. Like I think looking into some of those genetics and some of the raw data from the 23andMe reports, and as we further continue to get more information, it's still such a new emerging field and new emerging technology to test these genetic variations. I think that's going to ultimately be the future over specifically looking at certain the susceptibility of an individual to side effects or benefits from a certain drug. And I know Emily Deans is one of the great leaders in this, and she's put out a lot of great articles recently talking about this. And I think I'm going to try hopefully get her on the show to talk about some of her, because she's such a great writer and is able to describe these fairly complex topics and put them in a very readable and accessible manner. So hopefully we'll be able to get her on at some point. But I guess I'd love to, as we sort of kind of come to a close, I was realizing this may be completely stepping way back, but I'm sitting here hearing you share all of these thoughts and ideas, and you did describe, yes, when I first kind of went into medicine and your traditional training, how very different your current practice is based off of your when compared to your original training. But I'm also kind of curious, when did you? I'm sure your 8-year-old self had no idea what you would be doing now, but was curious if there were any sort of formative experiences, or hopefully not any adverse childhood experiences, but any kind of early experiences that pushed you in this direction to want to help others in medicine, and maybe at least be a little open to something outside of the traditional realm.
Well, I think my interest in psychology actually started in college when I was studying anthropology and cultural anthropology, and I started looking at rituals in different cultures, and it was interesting to me that people who do rituals in our culture oftentimes, get an OCD diagnosis, whereas in traditional tribal cultures, rituals are really important in terms of maintaining the health of the members of the tribe. And so I started from that place, and then was fortunate to have a mentor in the psychology department in my college who encouraged me to do an independent study, where he sent me to the locked ward of the hospital on the campus to interview people who were acutely psychotic. And I was a senior in college with no idea that I was going to want to go to med school, and that was when I had my first experiences with people dealing with psychosis. Just the light bulb went off, and it was like, well, these are my people. I've finally found who I want to be working with. And so, it was a little bit of a circuitous route, because I had to go back and do a couple years of pre-med classes before med school. But I was pretty clear that I wanted to go to med school for psychiatry. But even then, it wasn't really, I didn't have any thoughts about integrative work or, progressive approaches in psychiatry. I was kind of more on the psychotherapy, kind of psychoanalyst kind of track at that point. And then it was this really amazing experience I had, I wanted to share with you. A couple years after I got out of my residency, I had started a private practice, and I was doing all the things I knew how to do. And I might have shared this story at the Functional Forum, but this was in 2004. I had a patient with really bad agoraphobia, and I had done CBT with him for a year and treated him with a SSRI and a benzo, and I was doing everything right according to what I was taught, and he was only about halfway better. And he left my practice, reemerged a year later, and I just ran into him in town, and he shared with me, I was so grateful, because he shared with me that he had gotten tested for celiac and came back positive, stopped eating gluten, all of his agoraphobia went away, went off meds, still no agoraphobia, no anxiety. Started a business, got engaged, was going to have the family he always wanted. And it was like, oh my God, the gut. Like, nobody ever made any mention about the gut. And I think we had one lecture, not even a whole course, but 1 hour lecture in med school about nutrition, And at that time, nobody really talked about gluten or knew anything about that when I was in med school. So it was really that experience with that particularly generous patient who had me start testing people and start looking at diet, and it just became a snowball, and it led into other areas of integrative approaches, and kind of kicked off this period of curiosity and reading everything I could find. So those were some important pieces for me over the years.
Wow, thank you for sharing that story. And I don't remember you sharing that on the Functional Forum. Maybe you did. It has been a while, but just really chills listening to hear that. And I think it just speaks to the truth that our patients are our teachers, and will tell us what works, what doesn't work, and what's truly healing. And we just have to be willing to listen and believe. And for me, I have a lot of faith in that process and questioning things, and always questioning the things that I think I know. And so thank you for sharing that, and for deciding you wanted to go back and do those classes, and taking the time and getting to this point, because you're just doing tremendous work with folks, and really trying to pioneer a new area of psychiatric treatment. So thank you for that. And I guess, to close, I usually kind of leave this last piece of the podcast for my guests to really open-ended to kind of share any final piece of wisdom or a story or a piece of advice, anything that you feel would really help the audience in any way possible.
Yeah, I mean, just building off of what you were just saying about our patients or our teachers, I totally agree with that. And I would add to that there are so many healing traditions all over the world for us to learn from. And, Western medicine is actually relatively young if you look at world cultures and world healing traditions. I've had amazing experiences collaborating with acupuncturists. I've sometimes had people go and work with a shamanic healer, for example, if they gravitate toward that style of healing and it's an appropriate referral. And so, for your listeners, I mean, especially for the trainees out there, I think going out and exploring and learning about the people in your community who are doing different kinds of work. And, just like it is in psychiatry, there are people who are doing great work and there are people who are doing not so great work in other traditions as well. So it's not that all practitioners are created equal, in terms of the quality of their work. But I think that's been a really big benefit for me in my practice is, getting to know the local naturopaths and learning from them, getting to know what we call alternative healers, right? It's
such a terrible term.
It's hilarious. I mean, it's like, okay, here's a 5,000-year tradition, and here's a few 100-year-old tradition, and we're going to call them alternative, and we're the whatever we call the dominant paradigm. So always keeping an open mind to the fact that our toolkit is just kind of narrow, and there's always more to learn. So continuing that process over a lifetime keeps me engaged and keeps me excited about practicing psychiatry.
It really is so wonderful, and I completely agree. I take, each day I think about how can I surround myself with people who have different skill sets, think differently than me, maybe have some fundamental similar principles and values, but surround myself with people who do tremendous work that I have a very little understanding of, and they can be a teacher to me, I can be a teacher to them, and try to just widen my worldview. So completely agree. I definitely will in the show notes have a diagram of the framework that you talked about in the beginning, and we'll probably put a link in as well to your guys' talk, the YouTube video from the Functional Forum for people to dive in even deeper with that framework. And would love if you wanted to share with people now how, if they want to follow you or read more of your work, how they can get in touch and follow you.
Great. So people can read some of my blog posts on my website, which is www.willvanderveer.com. We have Janet Settle and Scott Shannon and I also have a teaching venture that we call the Psychiatry Masterclass, and that website is psychiatrymasterclass.com. And anybody who wants to get a hold of me can contact me through my website. Wonderful.
Well, thank you again for sharing this conversation. And, as I alluded to earlier, I think this is just part one of a series of conversations with you. You have such a wealth of knowledge, and please, listeners, if you really enjoyed this podcast, reach out to us if there's, you guys have questions about some of the things that we talked about, to maybe help us, guide us into what you'd like to hear in another episode. But I would love to have you back to talk about some of the psychedelics and just nerd out with some more of the nuances behind this science. So hopefully you can find a time in your busy schedule.
We'll figure it out. Thanks, Rob. It's great to be with you.
Thanks. Well, have a great day, man, and I'll talk to you soon.
Great. Take care. Bye-bye.
Thank you for your presence and willingness to receive a new narrative, a passionate perspective, and perhaps a deeper sense of connection with our collective purpose. Please share this podcast with any and all that you believe will benefit from its intention to relieve one's doing and engage one's being. Please share your comments about the conversation on our podcast page and leave a review in iTunes so that the voices in this space can spread to all ears ready to receive it. Music credit goes to Dillingham for their song Vessel. Remain open, stay curious, and forever be love.
You walked on fire, and I know you tried.